Hello and welcome to this webinar today. My name's Stephen Small and I want to thank you just for taking the time to have a quick look at what I've got to show you. I was recently in Latvia making a presentation to the combined Russian and Latvian medical rehabilitation societies, and the presentation I was making was looking at the key differences between non-surgical spinal decompression and how it overcomes the limitations and shortcomings of traditional mechanical traction. I'm not going to go through the whole presentation today. I just wanted to illustrate one part of it, and that relates to the way in which spinal decompression distracts targeted spinal segments. And so I'm just going to show you a few slides which I hope will clarify this point more clearly. If you don't know me, this is me. As I say, Stephen Small. If you've got any questions and want to receive any of the papers that I may reference, then please do not hesitate to contact me either by email or give me a call. Okay, so typical traction table. Traction certainly in the UK is not commonly used. The Cochrane review, which looks at all the available evidence, shows that traction as a modality is not recommended for low back pain, and this is a sort of device that most people have been familiar with. A simple table with a sort of pulling force at the end. And the modern spinal decompression devices, this one is called an AccuSpiner, they have some elements which are comparable to traction in as much as there is a pulling force, but what lies behind the the computer with the nuts and bolts of what this treatment does make it drastically different from traction. And the elements, as I say, I'm going to focus on, it relates to the ability to distract targeted segments and the way in which we do that. Spinal decompression, this question, there's a number of papers which on this subject, but I suppose the key one was relates to a study done in 1997, single blind RCT comparing spinal decompression to traditional traction by a guy called Dr. Norman Shealy, who was a highly respected surgeon, and he took two groups of patients with common conditions and essentially gave a similar treatment. However, with the spinal decompression, he used varying angles of force application up to 30 degrees rather than a single point, and a number of other factors. But the key thing is what he was able to observe was, using fluoroscopy, that the ability to distract targeted segments, and he actually measured a 7mm distraction at L5. What he further saw was that by altering the angle of application of a force and the amount of distraction, you were able to open different spinal segments in a way that previously hadn't been observed. And as far as the results of this study, 86% of patients treated with decompression for disc herniation had good to excellent results, whilst only 55% of conventional traction patients had good result, and none had an excellent outcome. But the key here, I want to get this one component of it, this measuring the angle at which a force is applied and the effect that can have. Now, the origin of that is taken using vectors, but as far as the actual administration of this treatment, I just wanted to show you an example of one of the patient. The ability to mobilize and distract targeted segments opens up new possibilities to help with improving disc health, and this is just one example which I'd sort of slipped in from the Journal of Neuroimaging. But as far as the application of the force, we're going to look at the measurement of the angle. Here we have a protocol for an L5S1 treatment where there's a specified angle of distraction, and this is kind of like the first time that a series of protocols have been written down, not hard and fast, but I would say more as a guideline. You've got a point of reference from which to start. So here we have an example. This is a physiotherapist, and the device, very simple. If I can get my mouse there, this is an inclinometer, and by raising this decompression head very precisely within increments of sort of 5 degrees, can have a significant bearing on where the point of application of a given force is applied. So illustrating this with vectors, essentially we have a y-axis and the x-axis, and we're concerned with the angle of pull. Now if we pull along we can pull in a vertical direction, and I tend to think of a dog on a lead. We can pull it backwards or we can pull it upwards, and it will move accordingly. Now, as we increase the angle the pulling force makes with the horizontal, the component element of the force, the horizontal force, will decrease, and the vertical component of the force will increase. And the effect of that is to move the point of application of force along the x-axis. As you further increase that angle, then again the y component of the force increases even more, and the x component decreases, and so the point of application moves further along the x-axis. And this is all referenced in any sort of physics text. Undergraduate physics text would illustrate this. Now the significance of this from the spine and decompression is that, okay, here we can see a pulling force acting on a horizontal. But as we saw previously, when you change the angle of the pull, then the point of application of that force moves along the x-axis. And if a patient is lying supine with their knees bent to flatten the lordotic curve, this can focus that force at a specific level. It might not be 100% at that level, but the majority of that force is going to be around a given point along that x-axis, which corresponds to a segment of the spine. And so this enables us to distract specific segments, which is what Dr. Sheely observed in his study back in 1997. And as you further increase that angle, again, we know from the physics that the point of application of the force moves further along the x-axis, and with respect to the spine, that application enables us to further open the targeted spinal segment, and so on. It goes up to about 30 degrees to distract the specific segments. So this is one element of spinal decompression. How the force is actually applied is another area which I'll show in another short demonstration. But just wanted to illustrate that point, and I hope that's answered some questions. If it's raised any questions, then please do get in contact with me. My name is Stephen Small, and here's my contact details. Thank you very much for